So this is the June 2021 MEC Minute, and our topic for this month is going to be heat illness. I went back through our files and I discovered that we've talked about heat illness before, but we haven't talked about it since 2015. And in those days, we did it as a one-page review of the subject for discussion over the kitchen or breakfast table in the morning. So I thought I'd go into a little bit more detail. I want to talk about heat illness. It is June, it's getting hot, it's getting humid, and we are all at risk for developing heat illness or seeing patients who are suffering from heat illness. So before we get too far into heat illness, we need to talk about thermoregulation. So thermoregulation is how our body maintains an adequate temperature. So if it's cold outside, the thermostat turns on, it warms up the body, we maintain our core temperature of 99.9 or so. If it's hot outside, we have to get rid of heat, and that's something our body has to do in order to maintain, again, that normal temperature at which our body functions the best, which is around 99.9 as a core temperature. But when we talk about temperature, you got to remember that heat flows from hot to less hot. So when our body wants to maintain an adequate temperature, and if we're faced with a significant heat challenge, the body's goal is to move temperature from our core to the outside the body and to get rid of that heat. So heat's going to move from the area that's hot to hopefully an area that's less hot. When it's hot and humid outside, it may entirely be possible that the external temperature is higher than our core temperature, so the body has to work a little bit harder to get that heat out of the system. So our body maintains heat balance via 4 different ways. One is conduction, and that's where heat moves directly between one body and another. So there's a piece of metal, its temperature is 200 degrees. You touch it with your finger. There is conduction of heat from 200 degree bar of metal to your finger. That might be 98, 99 degrees. There's movement of heat from hot to cold. You receive a burn. Another way to look at it is your body is hot and you put an ice pack on your body, or you put an ice cube on your body. You are moving heat from your body to the ice cube. That ice cube then melts. The second way of maintaining our balance is convection. That is movement of air or water across our body's surface area. That's why we feel better with a fan. We're moving cool air across our body. That's why we feel better when we take our forearms and put them in a bucket of ice water, because we're hyperthermic or hot. The third way of maintaining balance in our body is by radiation. So that's where we kind of give off heat into another area, which is generally into the air, but there's no air movement to cause convection. So basically we're sitting still, there's no air movement across us, and we're just giving off heat, moving off of our body into the air, again with the understanding that the air temperature is cooler than our body temperature. And the fourth way that we maintain balance of our temperature, or maintain an adequate core temperature, is by evaporation. This is where liquid or sweat changes to vapor. When doing that, the movement of air, movement of sweat and evaporation takes heat with it. It is very important in a way for us to lose body heat and auto-regulate in dry, hot environments. Evaporation can be more difficult as a mean of maintaining pressure in those environments where it's hot and moist, because there's not as much movement of moisture off of your skin into the air, which may already be close to fully saturated with moisture. In order for evaporation to work, though, you have to be hydrated. Your body can only sweat if it has fluid that it can put out onto the skin to cause sweat, which can be evaporated into the air, taking heat with it into the air. So evaporation is a very important means of our body maintaining core temperature, but you have to be adequately hydrated in order to do it. Heat illness, and this is kind of a broad term, and we're going to talk about 5 or 6 different types of heat illness. But heat illness occurs when the body's under heat stress and it cannot thermoregulate. In other words, our body's heat gain exceeds the abilities of the body to lose heat. We have a subcategory of heat illness called exertional heat illness. That's where we have increased body heat because we're exerting ourselves, whether you're outside exercising, whether you're in turnout gear fighting a fire, but in whatever circumstance you are exerting yourself by using your muscles, your body is generating additional heat and you're not able to shed that heat, therefore you develop exertional heat stress. I think an important item you need to understand is that this is not a continuum. In other words, you don't start out with heat cramps and then develop heat syncope and then develop heat exhaustion and then you develop heat stroke. You can have any one of these symptoms without starting at one of the others. So you can be outside working in a hot environment and develop heat stroke even though you've not had any of the other clinical conditions. Although I suspect, and if you look at it, some of the symptoms related to heat exhaustion are similar to heat stroke. It's just heat stroke is more severe. I think the other thing you have to keep in mind is if you have heat illness on one day, it can increase your risk to have any of the forms of heat illness on another day. So if today it's hot and humid, you go outside, work in the yard, and you develop heat exhaustion, you go back inside, hydrate, and so on, you feel improved. The next day you go back out into the same weather and overexert yourself again, you are at increased risk to develop heat stroke on that day simply because you've had previous episode of heat-related illness the day before. So keep in mind, once you've had an episode of heat illness, it increases your risk to develop heat stroke on another day. Hyperthermia by definition, a condition where an individual body temperature is elevated beyond normal due to failed thermoregulation. We talked about thermoregulation. Your body produces or absorbs more heat than it dissipates, so your core temperature is higher than it should be, and you're not able to get rid of that heat. That develops hyperthermia. In our patients who are sick with an infection, we call that a fever. But if you're outside working and you develop heat illness and your core temperature goes up, we would consider that hyperthermia rather than a fever. And when extreme core temperature elevation occurs, it truly becomes a medical emergency. People with heat stroke, which is the most severe of the heat-related illnesses, they need to be cooled fast. Their temperature by definition is over 104 and they are critically ill, and if you identify a patient in that category, you need to start cooling them down before you even get to the hospital. So patients with extreme rises in core temperature, they are suffering a true medical emergency. They need all your time and attention to get their body temperature down. That needs to start as soon as possible in the field, long before you get to the emergency department. So hyperthermia, who's at risk? Well, athletes. We always think about the athletes, and part of the reason we're talking about hyperthermia right now is because the conditioning programs that high school football is starting, so we have to think about athletes. We have to think about those people who work outside, whether they're construction workers or others, law enforcement, firefighters, anybody who's outside. The thing about construction workers is they tend to have time to acclimate, so they start working in the spring, and as the temperature rises, they become more acclimated to extremes of temperature elevation. So construction workers may not be as at great at risk as others. You have to think about the elderly and the very young. Think about those times in previous summers where you hear about the number of elderly in Chicago who died because they are shut-ins. They may not open their windows. They may not have air conditioning or a fan. Their temperature in their home goes up and up and up, and they become hyperthermic simply because they're shut-ins and don't have adequate cooling. You can also think of the very young as having trouble with hyperthermia. Both of these age populations have trouble with thermoregulation. Excuse me. For the elderly in particular, medications are also an issue. So for the elderly who are shut in, it may not be just that their apartment is hot, but they may be on medications that can increase their risk for hyperthermia, and we'll review a couple of those meds. So who else do you think is at risk? Well, it's you. You, as firefighters, are out there in the heat. You know better than I what the circumstances are and the conditions under which you work. When it's very hot out and you're in turnout gear, what's your process? Think about what your process is to maybe add extra companies to the assignment, to cycle people in and out more frequently. What's your limit going to be? Is it going to be 1 bottle of air and then you're out for rehab? Is it 2 bottles? At what point do you start cycling your crews because your crews are at increased risk to develop hyperthermia as a heat illness because of your working conditions and the equipment you have to wear? So risk factors, There are some. Poor acclimation and irregular exposure to heat stress is one of them. So, if you live in Michigan and go down to Florida to work for a couple of weeks and you're down there and you've got a big heat exposure, you're poorly acclimated. It's like me going from Columbus to 9,000 feet in the Rocky Mountains. I'm not acclimated to the high altitude yet, so I'm going to have problems up there. Same thing with heat illness. If you're not acclimated and you get exposure to significant heat stress, you are at increased risk for hyperthermia and heat-related illness. Poor physical fitness. Patients and people who are not physically fit are at increased risk to develop heat injury. Patients with cardiovascular disease and sleep deprivation are also at increased risk for heat illness. For cardiovascular disease perspective, you may not have the capacity to increase your heart rate as necessary to help move more blood to the skin so your skin can radiate that heat away. You may not be as tolerant of the heat stress and your heart may suffer, so it may be easier to have adverse effects of the heat exposure if your heart's not working well. Medications such as anticholinergics and antihistamines, beta blockers, and diuretics can all increase the risk for heat exposure and heat-related illness. And think about the diuretics. If you have to be well hydrated to sweat and lose heat, diuretics tend to make you volume depleted, so you may not sweat as well. You may not accommodate, or your body may not accommodate to the heat exposure and the heat stress because you're hypovolemic secondary to the diuretics. Inadequate pre-event hydration is a risk factor. If it's a hot day and start your hydration during morning report and keep hydrating during the course of the day. We mentioned today elderly as being at risk for hyperthermia. So elderly are more likely to develop heat-related illness. Be especially cognizant of that, particularly in the hot summer months when you go on a run on an ill elderly and you walk in the apartment and it's very hot. So think about that. Other risk factors include being an athlete or being a firefighter. That's because of the heat stress that you and they may be exposed to during the course of the day. So you have to think about that as well. Prevention, acclimate to the heat over 10 to 14 days. So if you are going to start working or doing something that's going to require a lot of outside work, outside exposure, start thinking about how you can acclimate to the heat. Get outside, do some gentle exercises or walking, start slow, start earlier in the day, and acclimate, increase your heat exposure over the course of the next 10 to 14 days. I realize that may not be the easiest thing to do when you're working every third day, but if you know the heat's coming, get out there and start acclimating. Think about frequent cycling of your crews when you're doing something. So if you have a big vent going on and you think about calling an extra company so you can cycle your crews in and out. They can rehydrate. They can take their gear off and cool down and take advantage of the things we may have on scene, such as fans, cold water baths, cold towels to help get the crews refreshed and back to work. Hydration, again, starts with the morning report. Start the fluids and keep it going. Think about what color is your urine when you urinate. If it's clear to light yellow, you're well hydrated. If it's dark, you need to start pushing more fluids. In the past, there's been discussion about avoiding caffeine. Caffeine is a mild diuretic. There's concern that caffeine may cause dehydration. I think some of the more recent studies suggest caffeine may not be as big a deal as previously thought, but I wouldn't just drink caffeinated beverages as part of your hydration. You also need to consume beverages that are not caffeinated. I think you need to think about how you're going to have organized and mandated rest and hydration, whether it has to do with a fire scene or training. That has very much to do with what happens for athletes during their early weeks of training. You rest frequently, you take previous fluids, or you take lots of fluids. The previous days of you don't take any fluids during training because it's an unmanly thing to do, I think those days are gone. There should be water available and readily accessible to all people who have significant heat stress. Think about those things that you actively and passively cool. Passive cooling could be just taking your clothes off, let your body give off heat. More active measures could be ice cold towels, putting your forearms in buckets of ice water, misting, or cool fans. And the other thing you need to think about as prevention is before that big event occurs, what is your department's policy or procedure to have a medical sector? When do you start cycling people in and out? Does somebody monitor firefighters' vital signs and mentation after they come out of active suppression or overhaul, and get reassessed before they go back into the fire ground? So those things, that's a question to think about locally within your department. If we have a big event and it's 98 degrees with 90% humidity, what are we going to do? And are we going to assess our firefighters as they come off or out of the building and start rehab? Are we going to provide a medical assessment to make sure they're fit and able to go back in when it's their turn back in rotation? Assessment and treatment, I think the biggest thing you need to do as part of an assessment and treatment for heat-related illness is have a high level of suspicion. So if you come across a patient and they have symptoms suggesting heat-related illness and it's hot out, think about whether or not they might be hyperthermic. Think about whether or not heat may be contributing to their current problem. Really, vital signs and mental status are some of your best parameters, things that you can measure. Are they tachycardic or not? Are they awake and alert, or they have altered level of consciousness? A temperature is good. At the hospital, we like to use either a rectal or esophageal temperature probe to get a patient's temperature. I'm not suggesting that you do rectal temperatures in the field, but at least check an oral or axillary temperature. If the oral temperature is 93 and the patient's obtunded and they come from a hot environment, to me that's a heat-related illness until proven otherwise. We also at the hospital sometimes use a temperature sensing Foley. Those are another acceptable way of monitoring the temperature. But if the patient's hot, we got to cool them down, and we need to keep track of their temperature and make sure the temperature is dropping and not going up. Just talk about some of the minor forms of heat-related illness. Heat rash is out there. It's kind of like an itchy red raised rash, similar to what I've got there as a picture. You may see little what appear to be pustules or milia. It's a medical word for pustules. You may see that there, and it typically occurs with heat exposure, particularly in areas where clothing is in close contact to the skin. The treatment for this is to gently cleanse the area, allow the skin to dry, and to change to dry clothes. Current recommendation is that for this type of problem, this type of a rash, cotton is better than polyester. It seems to be less irritating to the skin. How do you prevent the heat rash? Well, part of it is hygiene. Just bathe regularly, keep the skin dry as possible, and cotton clothing, particularly in the friction points. Sunburn, I think we're all aware of. If you're outside training, put your boonie hat on. But it's red, painful skin, and you may see blistering. We can treat that with skin lotions. If there's a lot of blistering, then medical care is appropriate. Blisters from sunburn are essentially a second-degree burn. So if you had somebody with a thermal injury with a second-degree burn, you'd take them in for treatment. Same thing with somebody who develops skin burns or skin blisters because of sunburn. Prevention, it's pretty straightforward. Shade, wearing protective clothing, and if you're going to be outside in the sun for a prolonged period of time, use sunscreen with at least an SPF 15 or more. Typically, I go 30 or 45, but use protective lotion to prevent the risk for sunburn. So that sunburn for us is preventable if we know ahead of time and use appropriate equipment and sunscreen. Moving on. Heat cramps. Heat cramps is probably the least dangerous of the significant heat illnesses. It's typically patients have fatigue and sweats. They may have cramps of their arms, legs, and maybe their abdominal wall muscles. But these patients are mentating normally. They're thinking clearly. They have no alteration to the level of consciousness, and their body temperature is either normal or just mildly elevated. Patients with heat cramps can be easily treated with rest and cooling. Oral fluids are good. Gentle massage of the muscles are good. If you want to slip in some Tylenol, that's probably okay. Patients with heat cramps after hydration and rest and symptom resolution can return to work. If they return to work, they should be monitored and they should have ongoing hydration. So, keep encouraging the fluids. Heat syncope is a heat illness. And it's basically patients have altered a level of consciousness secondary to heat exertion and in a hot environment, and because of that they may have decreased CNS perfusion. So these patients seem faint or lightheaded. They may have a transient episode of syncope or loss of consciousness. Sometimes these patients develop nausea and vomiting. They typically are tachycardic, and they may be a little hyperthermic. So for us, we're going to say any temperature less than 104 is not heat stroke. So heat syncope, by definition, core temperature would have to be less than 104. These patients need rest and need to be cooled. I would aggressively cool them, because if their temperature is elevated, you don't know if it's going to go up before it starts to go down again. So cooling is good. I would use active measures such as wet towels, forearms in cold water, misting or fan, whatever you have available. I think oral hydration for most of these patients is adequate. If you have a patient that is not able to take oral fluids because of nausea and vomiting, you have to start an IV. When you have patients like this, though, you also have to think about what else could be going on. So always think about alternative diagnoses that can be giving patients similar symptoms. So yes, it may be hot out. The patient may have been overexerting themselves, but are there symptoms due to heat syncope? Or could it be due to hypoglycemia because they're diabetic, took their morning medications, but have not been eating well? Or are they diabetic and hyperglycemic? Or are they not diabetic, but they have a cardiac arrhythmia at play? So patients with heat syncope, also think about those other diagnoses, other conditions that have been contributing to the patient's transient altered LOC or lightheadedness and so on. So always think about the other things as well. Patients with heat syncope need to be removed from work. They need to be evaluated from the medical perspective. These are not patients that are going to be amenable to rehydration on the scene and returning to work. So patients with symptoms suggesting heat syncope need to be transported, and they need to be evaluated in the emergency department. So they may still be discharged home, but you have to bring them in so we can get an idea what's going on with them. Heat exhaustion is another type of heat illness. These patients just feel exhausted, and it's because they just have an inadequate circulatory volume and they are dehydrated. So these patients typically have symptoms of dehydration. They may also have a headache. They might be lightheaded and dizzy. They may have cool, clammy skin. Again, heat exhaustion patients have a core temperature less than 104. If you look at these symptoms and compare heat exhaustion to heat syncope, they're very similar. But I think the approach in terms of assessment and so on is similar. And, it's a heat illness. You need to decide if it's heat exhaustion or heat syncope. I'm less concerned with that than you actually identify this as a heat illness and patient needs hydration and needs to be seen. These patients with heat exhaustion, they have cool, clammy skin, and they have a core temperature less than 104. You can control their nausea and so on with Zofran if you need it. The patient needs rest and oral fluids. IV hydration may be necessary. I think if you're called to the scene to assess a patient with heat exhaustion, I would start them on IV fluids, getting on the road to recovery. They need to be on a cardiac monitor to make sure that they don't develop an arrhythmia. You need to check their vital signs frequently to see if they're hypotensive or not. If they are hypotensive, I would definitely start an IV and give them an IV fluid bolus. Patients with heat exhaustion also need to be removed from work. They need to be evaluated by a physician. So they need to go to the emergency department. Heat stroke is the big one. That's the one you don't want to have. This is a deadly illness. So these patients have acute severe hyperthermia with organ dysfunction and organ damage. When I bring this up, I think about the soccer referee I had a couple years ago. He was out coaching or he was out as a referee all day in the hot, humid weather. He became lightheaded. He was hyperthermic for EMS. When he came to the emergency department, he was tachycardic. He was in acute kidney injury, acute kidney failure. His core temperature was just over 104. And he also had evidence of rhabdomyolysis. So, acute heat stroke. We cooled him down rapidly. We started him on IV fluids, and he gradually improved. And actually, in a couple of days, his renal function was normal. But patients with heat stroke, they have a core temperature at least over 104. Some articles will say 105. I think if you wait to get it that high, you're doing the patient a disservice. if your patient's core temperature is 104, it's time to act. These patients typically have altered LOC. They are typically dehydrated. Their skin can either be hot and wet or hot and dry. Typically, they're hot and dry because they just can't sweat anymore. These patients tend to be tachycardic and hypotensive, and they may have significant episodes of vomiting and diarrhea as the body's response to the heat injury. These patients need to be rapidly cooled. These are the ones you put ice packs on, you take their clothes off, you get them as naked as you can in the vehicle. If you have the opportunity to get some ice on them, ice packs or ice itself, but you need to get these patients cool. Sometimes these patients will actually put in a tub and put them in ice, so we basically pack their whole body in ice to get their temperature down. We need to get IV access and IV fluids. Cardiac monitoring is absolute because these patients can develop arrhythmias, and these patients deserve emergent transport to an appropriate facility. So these patients are quickly assessed, IV hydration, you get them cooled down as quickly as you can using whatever modalities you have. You get them in the truck with a cardiac monitor and you get to the hospital. These patients are sick. Complications, heat cramps, heat exhaustion, heat syncope, no long-standing effects. Heat stroke, you can have long-standing effects depending on what organs are affected and how bad the condition is before it's corrected. So you can have long-standing end organ damage. You can have neurological impairment. You can go from having normal kidneys to kidneys that are damaged. You can develop rhabdomyolysis, which in itself is a medical emergency and can cause problems. And rhabdomyolysis can also contribute to renal failure. So these patients are really sick and have significant risk for long-term complications. Just a couple comments about firefighters and heat. I'm going to reference an article that came out a number of years ago from University of Southern Illinois with some studies they did on firefighters. If you look at firefighter deaths, and this data is a little old, but I think it's consistent. Firefighter deaths, over 50% of them are cardiac death. They're not patients, they're not firefighters who die from an injury or from smoke inhalation or from an auto accident. The majority of firefighters die because of sudden cardiac death. And if you look at the cause of the injuries that resulted in death, over 58% of the causes of the sudden cardiac death and all firefighter deaths is overexertion and stress. So medical issues, and heat stress is one of those issues that we have to deal with. In the summertime, heat stress is even worse. This is a study, this is a graph out of the publication, and they looked at core temperatures for firefighters during interior attack, exterior attack, ventilation maneuvers, and overhaul. And these are core temperatures. And when I put this up here is because overhaul, so firefighters doing overhaul actually had a greater core temperature than any other tasks. Which kind of tells me that if you look at your exposure to noxious gases and your exposure to heat, overhaul is probably the most dangerous thing that you do because we know about those noxious gases. The days of doing overhaul with a surgical mask on are gone. You should now be in your SCBA, and your risk for hyperthermia is greatest during overhaul. So just something to think about, and you may think about how you cycle your crews. If you're cycling your crews, are you cycling them as much during overhaul as you did during the initial suppression? We have our own protocol within our MEC protocol. This is a copy of it. It has to do with heat illness. Look at it. It goes through heat cramps, heat exhaustion, heat stroke. It's all there. There is a comment to the left about watching for seizures. People with significant heat stroke can have neurological complications, and one of those could be a seizure. And if patients having seizures, patient really shouldn't be hydrated orally. But oral hydration is otherwise okay. And the last table that I have here really has to do with firefighter rehab. And this is out of a monograph. I think Massimo sponsored it probably 8 to 10 years ago. It's a little old, but the information is still current. So this is a concept of how do you approach firefighter rehab, with the idea being that as the crews are cycled out of the fire scene, out of suppression duties or even rehab duties, they go to a rehab section and they are assessed. They have parameters measured, their vital signs are normal or not, they're maintaining normally or not. If they are doing okay from a medical perspective, oral hydration, let them cool down, reassess after 10 to 20 minutes, and if they're still doing well, they can return to the fire ground. If their medical assessment shows that they're not normal, get them undressed, let them hydrate orally, let them rest for 20 minutes, and reassess them every 5 minutes just to make sure they're doing well as part of their rehab process. If they recover and take in oral fluids well, they can return to the fire ground. If they still are not doing well, at some point they may need to be taken off the scene, put into an EMS vehicle, and taken to the hospital for an assessment. But really the important thing is that we have an organized process to assess our firefighters on the fire ground, particularly as they're coming out of the interior or as they're coming off doing overhaul. So the idea is to identify the ill firefighters before they get into trouble. So something to think about. This is my only editorial comment for the day, but ask within your department, do we have a process, an organized process to evaluate the medical condition of our firefighters as they're being cycled through the fire ground? So that's all I have. I appreciate your time. Next month we hope to do a video on safe removal of football equipment. It'll hopefully be a real video and not a PowerPoint presentation. So more to come. We'll talk to you next month. Thank you.